Good morning. Welcome to Grand Rounds. My name is Alex Harris, and I'm one of the Grand Rounds co-directors, along with Drs. Aditya Lati and Rebecca Muley. I want to start by thanking the area leads and our chair for their ongoing support of sponsoring the food before and after Grand Rounds out of their personal funds during this austerity period. Next week, there will be no Grand Rounds, and instead we will celebrate the graduation of our fellows. The following week, the Office of Fairness, Inclusion, and Professional Development will be hosting Grand Rounds in honor of Pride Month. The speaker will be Dr. Richard Brandstrom, Associate Professor at the Karolinska Institute. The title of his talk is Structural and Biopsychosocial Mechanisms Underlying Sexual and Gender Minorities' Increased Risk of Poor Mental Health, a European Perspective. Before we introduce today's speaker, a reminder that if you are participating via Zoom, please post questions using the Q&A feature, not the chat. I am joined today online by Dr. Aditya Lati, who will forward questions to me for our speaker address. We encourage trainees to ask a question, and we will prioritize trainee questions, both in person and online. Please also indicate in the Q&A if you are a trainee. Please remember to fill out your CME surveys after the talk if you would like CME credit for today's lecture. There's a QR code on the table outside for those in person, and the link will be posted in the chat on Zoom at 12:15 p.m. It's now my great pleasure to introduce today's speaker, Dr. Negar Fani. Dr. Fani received her PhD in clinical neuropsychology from Georgia State University. She then completed a postdoctoral fellowship at Emory University, and in 2013, she started her faculty career at Emory, where she is currently an associate professor in the Department of Psychiatry and Behavioral Sciences at Emory University School of Medicine. For over 17 years now, she's been an investigator at the Grady Trauma Project, an ongoing trauma study in Atlanta. With that foundation, Dr. Fani has a really innovative research program using neuroimaging, physiology, ecological momentary assessment, and neuropsychological investigations to discover and treat the cognitive and affective consequences of interpersonal trauma in minoritized populations, with a particular focus on attention and interoception. Her work develops novel neurostimulation technologies in order to augment existing interventions, such as mindfulness, and she also partners with community organizations to assess intervention acceptability. Dr. Fani's research has been funded by the National Center for Complementary and Integrative Health, NCCIH, I had to look up what that was, and NIMH, as well as several foundations. And she has won numerous awards for her research, equity work, and mentoring as an active member of ACNP, where she is the chair of the Women's Committee. I've also heard that she's a Persian cat enthusiast, but I have not personally seen any photographic evidence of that to date. The title of her talk today is Neurophysiological Signatures of Minoritized Stress and Neurostimulation Technologies for Stress Relief. Please join me in giving her a warm welcome.
Thank you for that warm welcome. If anyone wants any photographic evidence of my love of Persian cats, I'm glad to supply it. Thank you so much for this wonderful invitation to be here. It's very meaningful for me to be here at Columbia today during a very challenging time, we can say. What I'm going to be talking to you all about today are some data that's been collected over the years looking at brain signatures or neurophysiological signatures of minoritized stress. And in keeping with my role as a clinical psychologist, some strategies for stress relief. I don't really have disclosures that are relevant to my work. These are honoraria that I've received. Our learning objectives today are to identify coping mechanisms employed in the face of minoritized stress, to identify neurophysiological biomarkers of these coping mechanisms, and evaluate the value of somatic therapies and interventions with exteroceptive augmentation for stress relief. So what I'm going to be talking about today are manifestations of marginalized stress, and I'm going to be sort of breaking this down into two big groups. One part of marginalized stress I think about as high effort coping. That includes issues like hypervigilance, heightened environmental awareness, as well as internalized emotions like ruminating about things that have happened to you. I'm also going to be talking about a different type of response that sort of involves physiological withdrawal, a shutting down response that can be manifest clinically as dissociation. I'll also be talking about some novel tech-driven ways to help people feel relief from their stress and reconnect with themselves. So I'm going to start out talking about marginalized stress more broadly and what are the effects of marginalized stress that we can see on the brain and behavior. And what do I mean by marginalization? So being marginalized means being pushed away from the center, to be disempowered, to be treated as inferior or different from others who are in the dominant group. And marginalization can happen in different ways. It can happen in response to something like your skin color, your race or ethnicity. It can happen in response to gender, sexual preferences, religion. There are many different ways in which people can feel marginalized. And I'm going to start off with talking about some data on the prevalence of experiences of marginalization. And this is some data from the National Center for Health Statistics that asked people about their experiences of being discriminated. This is really about race and ethnicity, and asked people of different racial and ethnic groups, have you experienced these different types of problems at least a few times in the past year, like receiving poor service in a restaurant, being treated like you are intellectually inferior, other types of things. And what they found was that particular racial and ethnic groups report experiencing this more frequently than others. So Hispanic, Black, and American Indian, Alaska Native individuals report this happening at least 50% of the time, that they've experienced at least a few of these types of things in the past year. And this kind of discrimination isn't something that just emerges in the context of adulthood. So we have a lot of data from the ABCD study, the adolescent brain and cognitive development study. This is data that just came out from Dylan G's group that shows that kids, including younger kids and adolescents, report experiences of discrimination that seem to kind of escalate over time. And this is true especially for Black, other or multiracial individuals, people who identify as AAPI. So if you look at the chart on the left, you can see this increase in discrimination reporting over time. And that another thing to note is that Black adolescents report this to be generally higher than the other racial and ethnic groups. So this speaks to the fact that even kids can recognize experiences of marginalization. This seems to be occurring more and more over time. In this study, they also noted that if you have an immigrant background, this is actually more frequent, and particularly within Hispanic groups. These data are really interesting in that it shows that there are differences in how we perceive this to be a problem. So this is a complicated graph that I'm going to talk to you about because I think this really illustrates how many groups in society don't recognize that this is a problem and how it can impact people. So this Pew Research Center poll asked people about their views on racial discrimination and asked about, when it comes to racial discrimination, the bigger problem for the country today is, and they broke it down by different racial and ethnic groups. And what I want to focus on first is in green. So in green represents that people do not recognize the problem where it really does exist. And you can see the difference between Black people reporting that this is an actual problem that people don't recognize versus white respondents. And when you look at the opposite, in gold, this is people seeing racial discrimination where it really does not exist. So essentially, people reporting are answering about, is this really perceived as like not really a problem? Is this how people see it to be? And it's clear that a much larger portion of white respondents reported that this isn't actually a problem as compared to white individuals. As compared to Black individuals. So you can see that this difference in how people perceive the problem can really affect people's inner experiences with marginalization. If you see that the people around you don't see this to be an issue, you're going to internalize your emotions about it. You're going to experience it very differently than if there is a public acknowledgement of the problem. There's a lot of data to suggest that there are very real health disparities between racial and ethnic groups. And because of the nature of my research, I've focused a lot more on Black populations. These health disparities in Black versus white populations are very stark across different types of metabolic disorders, cardiovascular disorders, diabetes. So if you're Black, you have a much higher risk of developing these problems. But when it comes to brain health in particular, you can see that the disparities are even more stark. So if you're Black, the risk of developing dementia, including Alzheimer's disease, is you have twice the amount of risk. If you have a problem like a stroke, it's a lot more debilitating. And for Black women in particular, the risk of death from stroke is much, much higher. And these statistics on brain health disparities in Black populations have been very meaningful for me. And I've had an interest in understanding, how do these prevalence differences come about? What are some of the factors that can be contributing to that, inclusive of discriminatory experiences? So I'm going to be sharing you more data now on marginalized stress in the brain and give you context into this project that Dr. Harris has mentioned I've been a part of for over 17 years. So I've been a part of a study that's examining risk factors for post-traumatic stress disorder in the context of an urban population in Atlanta, Georgia, for a really long time. So this is a study that was started by Carrie Ressler and Beck Bradley. Carrie Ressler is now over at Harvard, and Beck is now at the head of the Atlanta VA. And they wanted to understand, what are some different risk factors for PTSD from a biological and environmental perspective, and recruited historically people who were coming to Grady Memorial Hospital. This is a publicly funded hospital in Atlanta, Georgia, and recruiting people from the general population. So not psychiatric patients, but people who are waiting for their appointments in the waiting rooms, their approach to be part of the study. We currently recruit from the broader community, but it started out with this one project and is now many projects. But to give you an understanding of our demographic, the majority of people in our studies have been Black, mostly women, 18 to 65 years old. And we have data, both biological and clinical in nature, from over 13,000 people. To give you a sense of the socioeconomic status of many people, so this is the monthly household income. Most of our participants report a monthly household income of less than $2,000 a month. These statistics were from our earlier study that's showing 55% had $1,000 a month or less of monthly household income. So there's a lot of stress on that regard of trying to make ends meet. But these are the types of traumas that people report in our population. So traumas like physical assault are very common, either witnessing or directly experiencing these things. Gun violence is particularly a problem. And when you experience more trauma, you're at higher risk for developing problems like post-traumatic stress disorder and major depressive disorder, these trauma and stress-related problems. So in gold are the 12-month prevalence rates of PTSD and major depressive disorder. These are the lifetime prevalence rates. These are really high. To have experienced symptoms consistent with PTSD that are about almost half of our population, that is a lot. So we see a lot of trauma and stress-related disorders in this population, and I've been understanding a little bit more about why this is true. The way that I've started off in the Grady Trauma Project has been understanding visual attention, factors that influence how people attend to incoming information differently if you have PTSD versus controls who don't have PTSD. And I implemented this attention bias task, the DOT probe, in some of my earlier work to understand, are there vigilance patterns towards threat in these phases in people with PTSD versus any kind of biases away from threat? Some of the findings from my research were really interesting in that we did find an attentional vigilance for threat in our participants with PTSD, but this was specific to the white faces that were included in the stimulus set. So in our population that was Black, we found that there was an attentional vigilance for threat in these faces, but only when they were white. So that means that there was something about the race of the face that interacted with their symptoms to suggest a heightened vigilance. And this, I thought, really could intersect with experiences of discrimination or marginalization. This was really one of the first cues that I had that racial discrimination was a factor in some of the responses that I had in our population. When we looked at other things like fear-potentiated startle response, we saw that this greater vigilance for threat was associated with a greater amplitude of fear-potentiated startle, particularly to the threat cues, and sort of diminished extinction response. Further, when we gave this task inside the MRI scanner, we saw that not the amygdala was lighting up in response to these threat-related phases, but it was actually areas in the prefrontal cortex. So the ventral prefrontal cortex, dorsolateral prefrontal cortex in people with PTSD was more engaged. Again, showing differences that I wouldn't expect in someone with, typical PTSD. It showed sort of a greater engagement in those regulatory areas of the brain. And when I looked further into the effects of racial discrimination, co-varying other factors, so other types of trauma, post-traumatic stress disorder, and looked specifically at this type of social stressor, and this is work that was conducted with my colleague, Dr. Nate Harnett, who's at McLean. We administered this task, the affective Stroop, that involved images of people's traumatic experiences as they were doing a neutral cognitive task. And we looked at how frequency of racial discrimination affected their brain responses as they were performing the task. And one of the findings that came up was that there was a greater engagement as people reported more frequent experiences of discrimination. There was a heightened engagement in visual cortical areas of the brain. So this has a lot to do with environmental vigilance. We also found that there was a greater effect in the ventromedial prefrontal cortex. So as people had more experiences of discrimination, we saw a heightened response in this area of the brain that's tightly connected to the amygdala that suppresses threat responses, which was really interesting to me because it seems to be that there is a pattern emerging that's showing this increased engagement of vigilance and regulatory areas of the brain that may be specific to marginalized stress. There's not that much research that's being done in this area, but there's other studies that have looked at experiences of discrimination outside of racial discrimination. But this is work from Dr. Arpana Church in UCLA that's asked people about their discriminatory experiences due to all different types of factors, inclusive of racial discrimination, and looked across different racial and ethnic groups, so Black, Hispanic, Asian, and white individuals, and looked at differences in brain connectivity in people who report more versus less discrimination. What she has found is that there was a similar pattern of greater connectivity in the central executive network, so this regulatory network of the brain, in Black participants who had reported more discrimination. When you look at the other racial and ethnic groups, there's a lot of variability in connectivity patterns, but something that emerged that was common across all these different racial and ethnic groups when it came to discrimination was the default mode network. So this network was more connected in the context of greater discrimination across these different racial and ethnic groups, sort of suggesting that this may be a common network to internalized emotion, possibly related to discrimination. These are really interesting studies that sort of align with views of how racial discrimination and other types of discrimination work to affect people cognitively. So racial trauma scholars have suggested that there are different ways of processing experiences of discrimination that have to do with, first, sort of a heightened vigilance for threat in the environment. So people who have experienced more discrimination might be more attuned to things that might suggest that they may experience discrimination. They may prepare themselves for it in coming into an environmental context. And so this really suggests that there's this relevance of this heightened sensitivity to the environment and vigilance with minoritized stress. But there's another component of this as well, in that there is this heightened engagement in regulatory prefrontal areas of the brain. And this is something that is different from our traditional models of PTSD that suggests that minoritized stress involves having to sort of suppress your emotional response or ruminate about the event. And possibly if you're not experiencing it as sort of societal validation that it exists, trying to sort of reappraise the event and think about it in a different way because it's so at odds with your inner experience. And so this kind of coping response has been discussed in the context of racial trauma and stress as a way of sort of pushing through, sort of thinking about it, trying to make light of it, or use humor, or just simply suppress your response, because it may not be adaptive for you to sort of externally talk about the experience or show anger. And so this high effort coping response has been something that's been an attractive target for me for stress relief interventions, and I'm going to be talking about that in just a second. So what are the effects of high effort coping outside of in the moment? And what is the relationship of high effort coping in the context of accelerated aging? So some of the disorders that I talked about, like dementia, Alzheimer's disease, these are often thought of as aging-related diseases. And I have a student, Aziz El-Bashir, who's soon to graduate neuroscience PhD student, who's been interested to see how these coping mechanisms and brain networks that are involved with high effort coping and vigilance might be related to accelerated aging in the brain in minoritized populations. And he wanted to look at not just the typical subcortical structures we think of as involved with stress, but he wanted to look at brainstem regions like the locus coeruleus, the periaqueductal gray, the superior colliculus, areas that innervate networks of the brain that are involved with threat vigilance, as well as the default mode network, and wanted to see how the connectivity of these brainstem regions might be associated with experiences of racial discrimination in the brain and accelerated aging. So he also looked at DNA methylation age acceleration. So there are different clocks that you can derive from DNA methylation that sort of help us understand if someone's biological age might be exceeding their chronological age, suggesting a more accelerated rate of aging. What Aziz has found is that people who experienced more frequent racial discrimination showed a greater connectivity between the locus coeruleus, this main brainstem area that innervates adrenergic pathways in the brain, and the precuneus. The precuneus is a visual cortical region as well as a part of the default mode network. The network that we know is engaged during autobiographical processing when we're thinking about our life experiences. And this pattern of connectivity between the locus coeruleus and the precuneus was associated with DNA methylation age acceleration. So you can see in the graph here, as people reported more frequent discrimination experiences, they had greater connectivity, and this greater connectivity was associated with DNA methylation age acceleration. This significantly mediated the relationship between discrimination and accelerated aging. And we didn't have the data inside the scanner. This is resting state data to say that people were actually ruminating. And this is a psychological process that's relevant in this whole story. But we can see that there's maybe some neuroplastic effects of experiencing marginalized stress and an engagement in sort of this rumination, sort of chewing on or thinking about this process in a loop that might be contributing to age acceleration. And there's some other data to suggest that this, ruminative processing or internalized emotion might be contributing to accelerated aging. So Brooke McKenna was formerly a student over at Emory and is now faculty. She wanted to understand more about how experiences of marginalized stress and other types of stressors are associated with epigenetic age acceleration through how people cope with their emotions. And she was interested in anger internalization versus externalization. What she found in our sample of Black individuals in the Grady Trauma Project was that internalizing your anger, that mediated the relationship between lifetime stress exposure, inclusive of discrimination, and epigenetic age acceleration. This relationship was not observed with externalized emotion. So it seems like internalizing your feelings, sort of eating them, might actually be part of what can be contributing to accelerated aging in Black populations. And this sort of are aligned with our data that just came out last year about this. And so, these data and others, so we have other data that is structural in nature, showing that experience of discrimination also associate with decrements in brain structure. So you can see that more frequent experiences of discrimination associate with degradation in white matter microstructure, as well as cortical thickness, particularly in prefrontal areas. So our studies that we've looked at many factors that could be contributing to this. So not just discrimination, but other types of what we think about as PTSD criterion A stressors. We covaried for those types of experiences and wanted to isolate how discrimination may be affecting brain structure. We can see that this exclusively, or at least in part, could be contributing to these brain degradation and could be a potential effect of high effort coping. And this high effort coping is something that has been suggested to be a factor that's contributing to the weathering of people, contributing to not only brain health problems, but other types of health problems. So Dr. William Smith over at the University of Utah has looked at kind of a syndrome of hypertension, mental health problems in Black populations as a type of racial battle fatigue. The effects of having to internalize your experience of stress and push through and keep going. Arlene Geronimus has done a lot of work on experience of marginalization and weathering of the body and accelerated aging. And sort of these data seem to be aligned with the fact that having to internalize emotion, having this high effort coping may take a toll on the brain, including structurally. Obviously, as you can tell, a lot of this work has been cross-sectional, and it's been hard for me to understand what is happening first, what are the psychological processes that are engaged in the moment, how does that affect physiology in the brain? And so I'll be talking in just a minute about a study that we're doing to help answer those questions. But the third piece of this that I want to get to that I think is also important in the context of minoritized stress is how it can affect your disconnection with yourself, including the body. This is a quote from W.E.B. Du Bois, who has described a phenomenon of double consciousness in Black individuals, and Black Americans in particular, how this emerges. And this quote, "It is a peculiar sensation, this double consciousness, the sense of always looking at oneself through the eyes of others, of measuring one's soul by the tape of a world that looks on in amused contempt and pity. One ever feels his two-ness, an American, a Negro, two souls, two thoughts, two unreconciled strivings, two warring ideals in one dark body, whose dogged strength alone keeps it from being torn asunder." This is a very meaningful quote in that it describes how someone can experience their sense of self, their own internal sense of self, and also have to view the self through the eyes of others. When there is a discrepancy there, when there is a feeling like other people see you as inferior, this can lead to sort of this dual consciousness or double consciousness that is, at its very least, something that's effortful. It takes a lot of work to not only have to think about who you are as a person, but how other people perceive you and behave accordingly. I think about this work, I think about this kind of work in the context of phenomena that we see in the clinic, like dissociation, and how experiences of marginalization can lead to a disconnection from the body when the body is seen as a target for many individuals. You're sort of being characterized by something like your skin color or other physical features. And I think that experiences of discrimination, along with other types of inequities, can serve repeatedly to provide a dysregulation in how you experience yourself, including body signals, what we think about as interoception, our ability to detect our body signals and integrate them with our emotions. And myself and Saab Khalsa, who is now at UCLA, we've thought about how experiences of marginalization repeatedly and through different contexts can influence people's connection with their bodies and how this disconnection with the body can produce phenomenology like dissociation, where you're feeling disconnected from the self, disconnected from your surroundings. And this could be, in fact, mediated by dysfunction in the prefrontal cortex and the ventromedial prefrontal cortex in particular. So interoception has been something I've focused on sort of naturally as a target clinically. And some of the work that we've done in our lab has looked at physiological responses through like skin conductance. And in this study that I'm showing you here, we measured skin conductance in our Black participants when they were at rest and also when they were engaging in an effortful emotion regulation activity, breath-focused mindfulness. We looked at dissociation and PTSD and how it was associated with skin conductance and found that the more depersonalized you are, is the more blunted skin conductance you had at rest. But these symptoms of depersonalization associated with a much greater skin conductance when you were engaging in a high effort kind of regulatory activity. So there might be this tuning out or physiological withdrawal at baseline that sort of changes dramatically as people are asked to engage in something that involves regulating themselves. When we look at these data in the context of other neuroimaging data, we can see other evidence of interoceptive disruptions or physiological withdrawal or shutting down responses. So the study that you're looking at here uses the same affective Stroop paradigm. So this is a sample of Black women, and we sort of broke them up into two groups, high dissociators and low dissociators. We saw that the high dissociators had a worse performance on this task in the context of trauma-related cues. They also showed a disconnectivity in components of interoceptive networks, specifically the amygdala to the insula. We all know a lot about the amygdala's role in emotion processing, but the insula is very special in the way that it's there to sort of integrate not only emotional responses, but visceral responses and bring them together to help people regulate. So this disconnectivity seems to show a pattern of interoceptive dysfunction in our population. A very recent study that came out earlier this year, this is another one of Aziz's studies that looked at not only dissociation, but discrimination. What Aziz found was that people who reported more frequent discrimination showed a disconnectivity between the insula and the prefrontal cortex. Again, regulatory area that's also involved with interoceptive processes. And this disconnectivity between the insula and the medial prefrontal cortex was associated with greater symptoms of derealization, which is another type of dissociative response. So there seems to be this pattern that's emerged in people in our population who are experiencing marginalization and are sort of shutting down and not connecting with their physical experience as much. And this is seen clinically as dissociation, either depersonalization or derealization. So all of this research together has suggested some really interesting associations of marginalized stress with high effort coping and enhanced vigilance for the environment, as well as interoceptive disruptions. But again, we couldn't answer a lot of these questions definitively without understanding how people cope in real time. So we were fortunate enough, myself and many of my colleagues here, to get this NIMH-funded study that is looking at experiences of discrimination in real time. So this is a study that we're doing through EMA. People have an app on their phone and they answer about experiences of discrimination and their coping responses. They're wearing a Fitbit so we can see through actigraphy what their physiological responses are. Through neuroimaging, we fuse those data together, and we're trying to see what kind of brain signatures are emerging that are associated with not only experiences of discrimination, but coping responses. And this is something that we plan to use for future neurostimulation studies to see what are our best targets for individuals. So this work, I will say, it's as of this moment is still funded and is supported by a group of people who have expertise in so many areas related to this work. And I think not last but not least, we have a community consultant, and Ashley Dennis Silas is someone who works in the context of a large behavioral health organization in Atlanta. Her involvement in this study is critical, and I want to sort of use her presence here to highlight the fact that we need to have community consultants that are integrated in our research studies to make these things effective and meaningful. Sort of to move on to the next part of this lecture. So I've talked to you all a lot about how marginalized stress can affect the brain, how coping strategies emerge in an adaptive way after you experience discrimination, but I haven't talked a lot about how we can help people. And again, the real way that we can help people is changing policy. But as a clinical psychologist, I also look for ways to help individuals in the moment find relief. So that's what I'm going to be talking to you all about today, is this really novel tech that I think can make this stress relief faster. Before I go into what this device is and what I'm going to be talking about, I want to discuss the fact that, we have racial scholars who have mentioned how the body is affected by minoritized stress. And I want to say that there are people like Resmaa Menakem who have talked about the body as a source of healing as well. So he has described the body, not the thinking brain, is where we experience most of our pain, pleasure, and joy, where we process most of what happens to us. It's also where we do most of our healing, including our emotional and psychological healing. It is where we experience resilience and a sense of flow. It is, inspired by him and many other scholars' work who has sort of focused on how ignoring the body is ignoring an opportunity for healing for many marginalized populations. More and more, we can see that mind-body interventions are being suggested for marginalized populations, including socioeconomically disadvantaged populations, many of whom may be skeptical of traditional treatments, and also may benefit from interventions that are focused on the body as well as the brain. So among the things that have been suggested in Black communities, mindfulness-based strategies have been suggested, with mindfulness being a practice that's not only about keeping your focus present-centered on a particular target, but it's also about being non-judgmental. And if you think about marginalized stress as experiencing judgment from society and maybe even judging your own responses to that, this can be particularly useful or effective. And what we know about mindfulness neuroimaging studies is that mindfulness seems to be acting on the brain regions like the insula that we know to be involved with interoceptive disruption, so it's naturally a good target. But the problem with mindfulness-based interventions more broadly is that there's pretty high rates of attrition. So it's really easy to get someone to focus in the moment in a therapy session on their breath or whatever else is happening, but in the absence of maybe a therapist guiding this, it can be really challenging. So number one, it's a very effortful thing. For many of you who have practiced mindfulness, like myself, you know that it's really hard to sustain your focus on a single thing like the breath. The breath is a very subtle signal. And if you're already checking out from your body a lot, this is a really hard thing to attend to for a long period of time. And I'm not interested in things that really add burden to people's already stressful and overburdened lives. So in concert with the work of Dr. Greg Siegel, who's my collaborator, we've thought about a hack to not sort of ask people to engage in a sort of top-down way in mindfulness as usual, but to sort of hack somatosensory systems to help people engage through the use of a device. So what you're seeing is the device that we came up with that my model Daniel is wearing. And this device includes a sternal component where each time Daniel breathes, he's feeling his exhale as a vibration on the sternum. So with this, people are able to sort of feel their breath as a vibration with the hope that this signal coming exteroceptively may be a lot more powerful and easy to engage with. And through these sort of bottom-up networks, sort of capture people's attention, allow them to enhance their interoceptive awareness with potentially positive downstream clinical effects. So this is something that we've been testing in the context of our clinical trial between Emory and Pittsburgh. And we've really focused on how this kind of intervention can change interoceptive and attention networks. So those are our main mechanisms of focus. This is a study funded by the NCCIH. And people are randomized. So we recruit people from the community who report relatively high symptoms of dissociation, and not on the level of dissociative identity disorder necessarily, but almost all of our participants have PTSD, but they have elevated dissociation. And they get randomized to one of four groups. And this is a 2x2 design that's looking at vibration versus not, versus breath-focused meditation versus none. We have 8 intervention sessions. They're brief, they're 20 minutes, it's computer guided. People are instructed to focus on their breath or their breathing or focus on vibrations. And we get EEG data that we collected fairly recently through a new supplement. We collect blood data, we do cognitive assessments. We're looking at all these different ways in which vibration augmented breath focus or vibration alone may be affecting people's engagement, affecting interoceptive networks and attention networks. We also give feedback at the end. So we do 3 and 6 month follow-ups, and we show people their data. This is also one of the most powerful elements of this study, is showing people's data and asking about their experiences and seeing how they may line up. This study was recently featured in a PBS show called Your Fantastic Mind, which sort of brought together both our work on racial marginalization and this strategy for healing. If you're interested, please check it out. And this episode, I think, was nominated for Emmy recently. And so we've been looking at all the data from the study. We don't have the final data set analyzed right now because it's an ongoing clinical trial, but I have a postdoc, Tim McDermott, who has been interested in how this vibration device might be changing autonomic regulation, and not just looking at heart rate variability, what we think about, but respiration, how respiration rate and variability might be affected by the intervention. And what we're able to see with his data across the different intervention sessions was that the people who were getting the vibration augmented breath focus in red had lower respiration variability. So the variability in between breaths was lower and decreased over time as compared to the other 3 groups. So you may be thinking to yourself, like, why would you even care about respiration variability? Like, who cares about the variability in between breaths? This is actually something that could be indicating engagement in the intervention. So if you're maybe being more effective at doing breath-focused mindfulness, you might be breathing more evenly and more regularly. But we needed some emotion data to sort of see if that may line up with emotional experience. And what he was able to see was that less respiration variability was correlated with less negative emotionality, and that included feelings of anxiety or anger. So I think this really points to a metric like respiration variability as kind of a novel metric that we might want to look at in our clinical studies. It could indicate engagement. It might be something that sort of relates to people being more regulated in the context of this exteroceptive augmentation. We have some other clinical data that's been emerging to suggest that if you're getting a vibration-related intervention, so either pulsed vibration or vibration that's synced with the breath, you seem to have a better, easier time connecting with your body, being more aware of body signals. And this seems to increase a lot more rapidly in the vibration versus non-vibration groups. This question has come to my mind is like, are there any neuroplastic changes that are occurring as a result of the vibration? And we have some compelling evidence that hopefully will come out soon that is showing that it is. So we looked at vibration versus no vibration over time and saw that the people who were receiving the vibration showed an increased neurite density. So this is a metric of white matter integrity that's showing people who were receiving the vibration had a higher white matter density in the corticospinal tract. So this is a tract of relevance to somatosensory functioning, somatosensory integration, interoception. The region that showed the most association with vibration was the cerebral peduncle, which is connecting the brainstem to the thalamus. So it could be that this experience of having the vibration during the meditation may be strengthening the somatosensory interoceptive pathway. And when we look at the clinical data, we can see that the people who are receiving the vibration in red showed changes in this white matter metric in the corticospinal tract that associated with body dissociation. So greater improvements in white matter integrity associated with lesser body dissociation. So this is probably some of our most compelling evidence that shows that adding this vibration might be doing something actually physically to the structure of the brain that in areas that are most essential to interoceptive awareness. When we look at other things like engagement and retention, we can see that those who are receiving the vibration and the retention rates, these are the number of people who stayed in and didn't drop out between pre and post intervention. We had pretty high retention rates overall. And this is in a sample of about 130 people. You can see that the people who are receiving vibration had the highest retention rates of all. So there seems to be something about receiving the vibration that kept them engaged. When we do some qualitative analyses of the interviews from those feedback sessions that I mentioned earlier, we hear comments that suggest that this vibration sensation, even when they're not experiencing it, there's a sensory trace that people can hold on to that they may be able to use for regulatory practices. So this is a quote from one of our participants where she said, whenever I find myself getting anxious at home, it's like I can feel the vibration on my chest and I go with it. When I used to take a Xanax. Very seldomly do I have to do that anymore. I'm learning to become more in tune with my body. So it's really compelling hearing the stories of our participants that it seems to be that this vibration type of intervention is able to help them. We've had some curious and interesting ways people have sort of taken the tech and used it on their own. So we had someone program it on their phone so that they had a ringtone that vibrated with the same frequency, and they use their phone and put it on their chest when they're feeling stressed, and sort of do it yourself kind of hacks. I mean, I think it really speaks to the effectiveness of this type of intervention. So I want to wrap this up by first saying, it's really important to measure marginalized stress. If there's anything that I can emphasize to you all, is the fact that simply having a measure of marginalized stress, of discrimination, can be very validating, in addition to helping your own research. So it is important to incorporate measures of discrimination and marginalization in your research. And I think that we can see through different multimodal ways how high effort coping can be manifest, as well as these physiological withdrawal, shutting down, interoceptive kind of disruptions. And I think it speaks to the importance of having interventions that do have a somatic component. So there are many different types of mind-body interventions. I don't have a specific allegiance to mindfulness. I just used an adaptation of mindfulness in the context of my study. But there are many other types of somatic interventions that can be useful to marginalized populations. And these reviews are a really great place to learn more about them. I think that having more connection to the self is a conduit to social connection as well. It is really hard to connect with friends and loved ones if you don't feel any connection to yourself, including your identity. So I think about this as a pathway to social connection as well. And, I want to end this by saying that finding some way to add an exteroceptive component to interventions can be incredibly powerful. I've been talking about breath synced vibration in my studies, but there are other types of methods like transcutaneous vagal nerve stimulation that have proven to be really effective in trauma exposed populations. This is a different type of exteroceptive augmentation that could potentially boost the effects of something like a somatic intervention. And, in the absence of these kind of higher tech solutions, I ask my participants or my patients in clinic to add a sensory component to their practice. So I see a lot of folks who have a lot of emotion dysregulation, and they have a hard time just bringing the intensity of their emotions down and feeling anything but their anxiety. Having something like a yoga ball that's vibrating can be really powerful. And this is cheap, it's about $20, but having this sensory augmentation to your practice can actually produce big changes, we can see with the vibration results in our study. So this is a cheap way to sort of incorporate these sensory components. For those of you who are interested in understanding more about using this kind of tech in your practice, please let me know. We do have a way that we're thinking about sort of distributing this to clinicians who are interested. But the bottom line is that it's important to look at ways to sort of reduce people's cognitive effort or cognitive burden if it's a marginalized group in particular. The truth is that all of us could use probably a break. We have a lot of cognitively demanding activities, and looking to practices and augmentation to help people reduce the amount of effort that they need to engage is important, as well as having interventions that are low cost. So all of that being said, I want to end this by thanking the work of my number one, thanking our participants who have generously given their time and efforts and trusted us to do this work. The tireless efforts of my lab, who work really hard to help people engage in our research. I have wonderful collaborators too that I have to acknowledge, who are doing work in racial trauma and dissociation. The people at the Grady Trauma Project who continue to do this work, my funders at the NIH, and the people who created the pretty pictures. Please take note of their emails if you would like to see more of their work. They're willing to do it for you. And with that, I want to take your questions.